Imagine for a second, right, that you have a severe, just agonizing sunburn.
Oh, yeah, like the kind where you can't even stand to put a t-shirt on.
Exactly. Your skin is raw, it's peeling, and it's incredibly painful to even, like, the lightest touch. Now, imagine you go to the doctor, you're desperate for relief, and the standard go-to medical treatment they hand you is a lotion that, well, the very moment you put it on, it essentially sets that sunburn on fire.
Right. It's a total nightmare scenario for a patient.
It really is. And that paradox is actually the exact focus of our deep dive today. We're exploring a highly specific, totally fascinating medical puzzle, and we're pulling together insights from a huge stack of clinical guidelines, pharmacy compounding guides, and this really massive research study on mucoadhesive drug delivery.
Yeah, the data on this is just incredible.
It is. And our mission today is to look at how combining a very common anti-inflammatory drug, so hydrocortisone, with a highly engineered, totally water-free delivery system can actually heal a debilitating condition called desquamative inflammatory vaginitis, or DIV for short.
Which is a critical mission, really, because for so long in medicine, the focus has entirely been on the active ingredient, right? The drug itself.
Right. Just get the drug to the site.
Exactly. But when a patient's tissue is profoundly compromised, I mean, the cure can feel just as punishing as the condition itself if it's delivered the wrong way. The vehicle carrying the medicine matters just as much as the medicine.
Yeah, that makes total sense. And before we can really understand how this specialized delivery system works, we kind of have to understand the battleground.
Right.
Right? What exactly is the environment we're trying to heal?
Right, the pathology.
Okay, let's unpack this. I like to use an analogy. Imagine you're looking at a brick wall.
Right.
But the mortar holding it all together is just completely dissolving.
Right.
And the bricks themselves are like falling out of the wall before they've even fully baked in the kiln.
Yeah, that's a highly accurate way to visualize it. That is basically what is happening at a cellular level for you if you're a patient suffering from DIV.
It sounds so painful.
It is. DIV is a chronic, severe form of vaginitis. And the exact cause, like the initial trigger for it, is actually still a bit of a mystery to researchers.
Really, they still don't know what starts it.
Not definitively, no, but we do know it primarily affects perimenopausal white cisgender women. And the physical reality is incredibly distressing. You're looking at a combination of purulent discharge, severe superficial redness, which clinically is called erythema.
Erythema.
Yeah, as well as spotted rashes or bleeding in the tissue known as ecchymosis. And all of this leads to significant, sometimes entirely debilitating pain during sex.
And if you were to, like, take a swab of this environment and put it under a microscope, it really is just a scene of total cellular chaos, right?
Absolute chaos. I mean, to understand the chaos, you have to first understand what a healthy baseline looks like.
Right, the before picture.
Exactly. In a healthy vaginal microbiome, you have this abundance of protective bacteria, specifically lactobacilli. These bacteria are essentially the guardians of the environment. They feed on glycogen, and they produce lactic acid. And that lactic acid is totally crucial because it keeps the vaginal pH slightly acidic, usually, under 4.5.
So the acidity is like a chemical shield against pathogens.
Exactly, yeah.
So it's this perfectly self-regulating ecosystem, but in DIV, that ecosystem just completely collapses.
It completely collapses. In a DIV patient, there is a near total absence of those protective lactobacilli.
Wow.
Just gone, mostly gone, yeah. And because they aren't there producing that lactic acid, the vaginal pH just spikes way above 4.5. But, the high pH is really just the beginning of the problem.
Right.
The most defining destructive feature of DIV is that the body's own immune system essentially panics. It just goes into overdrive and triggers this massive localized inflammatory response.
So the body is sending in the troops, but the troops end up destroying the city.
That's a perfect analogy. The immune system floods the area with inflammatory white blood cells called neutrophils.
Neutrophils, right,
That's
for
it.
first responders.
Yeah, they're first responders, but they're super aggressive. This intense chronic inflammation leads directly to what gives the condition its name, desquamation.
Which is the shedding, right?
Yes. Desquamation is the rapid, totally abnormal shedding of skin cells. Going back to your brick wall analogy, the tissue is shedding so fast that it's losing cells before they even have time to mature and form a hard protective barrier.
The unbaked bricks.
Exactly. These are immature skin cells called parabasal cells.
Man. So the body is physically stripping away its own armor before it's even fully forged.
Right.
It makes perfect sense why the tissue would be so raw and painful. But What strikes me as a massive frustration for anyone dealing with this is how hard it is to even get the correct diagnosis in the first place.
Yeah.
Like we see over and over in the sources that DIV is a diagnosis of exclusion.
Oh, yeah. Patients are frequently misdiagnosed. I mean, often languishing for months or even years without real help.
Years. Wow.
Yeah. Because the symptoms, the discharge, the high pH, the burning otheanus, they heavily overlap with much more common issues. So primary care doctors will initially suspect bacterial vaginosis
Right. BV.
or trichomonas infection, or, they might just chalk it up to simple low estrogen vaginal atrophy because of the patient's age.
Which means the patient is put on standard antibiotics or like regular estrogen creams, and literally none of that stops the immune system from attacking the tissue.
Precisely. It doesn't address the root cause at all. It's only when all of those standard treatments for those other conditions fail and the other infections are, definitively ruled out that a clinician might finally look closer at the microscopic evidence.
And that's when they see the missing lactobacilli in the neutrophils.
Right. When they see the lack of lactobacilli, that abnormally high pH, and most importantly, that distinct flood of aggressive neutrophils right alongside those immature parabasal cells, that's when they finally realize, oh, we're dealing with an autoimmune-like inflammatory crisis, not a standard infection.
Which brings us to the treatment phase, and honestly, the massive hurdle we teased at the very beginning with our sunburn analogy.
Yeah, this is where it gets really tricky.
Because, wait, I'm kind of stuck on the logic of the standard protocol here. If the mucosal barrier is already completely raw, devoid of protective bacteria, and totally stripped of its mature cell layer, why are we prescribing commercial creams that are notoriously known to irritate mucosal tissue?
Well, it's the ultimate double-edged sword of standard care, right? It really puts doctors in a terrible bind.
Because they have to stop the inflammation.
Exactly. Because DIV is fundamentally driven by an intense, rogue inflammatory response. The only logical medical step is to use powerful anti-inflammatories to shut that immune response down. You have to stop the neutrophils.
Right.
So the go-to active drugs are usually 2% clindamycin, which actually has anti-inflammatory properties, or, much more commonly, topical corticosteroids like hydrocortisone. The hydrocortisone is absolutely vital to stop the cellular chaos.
Okay, so the drug itself is necessary. But the way we're handing patients that hydrocortisone the vehicle is where the entire system just seems to break down. I mean, we saw in the sources that sometimes patients are even instructed to go to the pharmacy and literally buy 25 milligram anisole rectal suppositories to use vaginally, completely off-label.
Yeah, they do. Because finding a tolerable delivery method for the hydrocortisone is just that incredibly difficult. The root of the problem lies with the basic chemistry of standard mass-produced commercial creams.
Okay, break that down for me.
So if you're a pharmaceutical manufacturer, right, and you need to make a hydrocortisone cream that can sit on a pharmacy shelf or in a hot warehouse for 2 years without growing mold or separating into a gross liquid.
Right, it needs a long shelf life.
Exactly. You are forced to add specific inactive ingredients. You have to add water for that creamy texture. And because you added water, you must add alcohols and harsh synthetic preservatives like parabens or propylene glycol just to stop the bacterial growth.
And if you have like intact, totally healthy skin on your arm, those preservatives are generally fine. You don't even feel them.
No, not at all.
But if you are a woman with severe DIV,
Right. If you have severe DIV, your epithelial barrier is so profoundly compromised that applying those standard commercial creams feels like applying acid.
ugh, that's awful.
It is. Take propylene glycol, for instance. It's an osmotic agent.
Meaning what exactly?
Meaning on raw tissue, it can physically draw moisture out of the already inflamed cells.
Oh, wow. So it's actively dehydrating the tissue that's already suffering.
Exactly. In fact, for a severe DIV patient, her tissue is so stripped that applying plain water, just plain water, can cause a severe stinging gradient.
Unbelievable.
So when you tell a patient to insert a water-based cream filled with synthetic preservatives and alcohols into a heavily denuded raw mucosal lining, I mean, the agonizing side effects often force her to abandon the treatment entirely before the hydrocortisone even has a chance to work.
And the workarounds for this are incredibly fraught.
Yeah.
Like, doctors are having to suggest makeshift solutions just to get patients to a single dose.
Yeah, it gets really improvisational.
Like, they'll literally tell patients to apply a thick film of plain Vaseline to the exterior vulva just to protect the surrounding skin from the burning runoff caused by the medicine itself.
Which is really not ideal.
No. Because by the way, medical guidelines explicitly state that petroleum jelly rapidly breaks down polyisoprene and latex condoms, and it damages silicone. It's a terrible long-term solution.
It is. Or, as you mentioned with the rectal suppositories, they tell patients to literally cut the wax suppositories in half with a knife to try and slowly build up a physical tolerance to the medication over a period of weeks.
It's just the brutal process for the patient.
It really is. And this raises an important question. How can we deliver the absolute necessity of the healing hydrocortisone without subjecting the patient to the agonizing, sometimes even harmful side effects of the delivery vehicle?
Right. And enter the compounding pharmacists.
Okay.
To solve this chemical burning problem, they basically bypass the commercial stuff entirely and turn to a highly specialized vehicle, specifically the anhydrous self-emulsifying base.
Yes. This is where the science gets really elegant.
I love this part. I like to think of this base as like a smart release sponge.
Yeah.
When it's just sitting in the tube, it's completely dormant. It's just holding the medicine. But the second it encounters the unique, specific environment of the human body, it activates its payload.
That's an excellent way to visualize the mechanism. When we talk about an anhydrous base, we're talking about a compounding base that is completely 100% water-free.
We roll water.
Zero. There are specific proprietary bases out there, like one called Elage, for example.
Okay, Elage.
Yeah. If you were to look at it, it's an opaque cream. It feels incredibly smooth to the touch. And crucially, for patients with severe sensitivities, it's engineered to be free of common allergens.
So no wheat, soy, gluten, stuff like that.
Exactly. No dairy, no nuts. But the real magic, the reason it actually solves the DIV paradox, is in its chemical design. It is a self-emulsifying drug delivery formulation.
Okay, so here's where it gets really interesting. If it has literally no water in it, how does it ever break down to release the drug? Doesn't it just sit there like a lump of wax? Like, how does it activate?
Well, this is where the chemistry is just so brilliant. Even though the base itself contains zero water, it is chemically formulated with specialized surfactants, and these are designed to actively seek out and react with water.
Okay, remind me, a surfactant is?
A surfactant is a molecule that has one end that loves oil and one end that loves water. So when the patient applies this compounded base, it comes into contact with human vaginal fluid. Now, even though DIV patients frequently suffer from severe dryness, there are always tiny residual mucosal volumes of fluid present.
And that human fluid inherently contains water.
Exactly. So the moment the anhydrous base touches that tiny bit of natural moisture, those surfactants go to work. The base spontaneously transforms. It emulsifies, literally turning from a dormant ointment into a dynamic microemulsion right there on the tissue.
So it's basically hijacking the body's own moisture to activate the drug.
That is exactly what it's doing.
That is brilliant. So the lack of water in the tube acts as a double shield then. Because there is no water sitting in the tube at room temperature, bacteria and mold literally cannot grow in it, right?
Right, they need water to survive.
Which means the compounding pharmacist doesn't need to add a single drop of those harsh burning preservatives or alcohols.
Yeah.
You just get a totally non-irritating sterile vehicle.
It solves the burning issue immediately. It's incredible. But the anhydrous nature of the base does something else just as critical for the hydrocortisone itself.
Oh, what's that?
Well, water naturally degrades certain molecular structures over time through a chemical process called hydrolytic degradation.
Okay, so the water literally breaks the drug down.
Basically, yes. Water molecules essentially attack the chemical bonds of the drug, rendering it way less effective over time. By keeping the hydrocortisone suspended in a completely water-free environment until the exact second of application.
You're protecting it.
Exactly. You protect the structural integrity of the active drug. You guarantee the patient is getting the full, potent dose of the anti-inflammatory, while simultaneously significantly extending the shelf life of the compound without using preservatives.
Okay, so I understand the chemistry of the emulsion, and I totally get why it doesn't burn. We have the active drug protected, and we have this clever, smart release base.
Sure.
Wait, I have to challenge the actual physical mechanics of this?
Sure, go ahead.
Because the vaginal canal is a self-cleaning, gravity-dependent environment, right? Fluid naturally flows down and out.
It does.
So if this base instantly turns into a microemulsion when it hits fluid, how does this medicine actually stay in place long enough to heal the tissue without just, washing out immediately?
You've just identified the single greatest hurdle of all vaginal and mucosal drug delivery. Getting it there is easy, keeping it there is the challenge.
Right.
And that brings us to a really fascinating scientific concept called mucoadhesion, sometimes called bioadhesion.
Okay.
This anhydrous isn't just a passive carrier. It is structurally designed at a polymer level to physically cling to human tissue. The polymers in the base form physical and chemical bonds like hydrogen bonds with the mucin glycoproteins and the epithelial cells lining the vaginal wall.
So it's essentially microscopic Velcro.
Microscopic Velcro is a great way to put it.
And the proof of this is just incredible. We read about this in the sources. Researchers conducted this ex vivo study using porcine or, big vaginal tissue to test exactly how strong this Velcro is.
Right. And they use pig tissue because the histological structure, the way the actual cells are layered, is remarkably similar to human mucosal tissue.
It's basically the gold standard for testing this kind of absorption, right?
Yeah. It absolutely is. And the visual evidence from that study is so striking. The researchers took the anhydrous and they infused it with a bright fluorescent dye called fluorescein sodium.
Right, so it glows.
Exactly. This allowed them to track exactly where the base was under a UV light. So they applied this glowing base to the pig tissue, and then for 90 straight minutes, they subjected the tissue to a continuous intermittent rinsing with a vaginal fluid simulant.
Which is wild. They were actively trying to flush it out, just fully mimicking the exact physiological conditions of a human body walking around dealing with gravity and natural fluid production.
Yep. They threw everything at it, and it held on.
Wow.
Even after 90 minutes of being aggressively flushed with fluid, the tissue maintained persistent fluorescence under the UV light. The anhydrous stayed firmly locked onto the cellular wall.
That's amazing.
It proved that it doesn't leak or wash away nearly as easily as standard over-the-counter moisturizers or commercial creams. It stays exactly where the inflammation is happening.
Okay, the retention is amazing, but sticking to raw tissue is really only half the battle.
Right.
Like, they also had to rigorously prove it wouldn't further irritate the tissue once it was locked on.
Right, safety first.
Because if you're a patient who has been burned by creams before, you want solid proof it's safe.
Yeah.
And they proved it using something called the HET-CAM test, which, and I love this, stands for the hen's egg test on the choriolentoic membrane.
It's quite a mouthful.
It sounds like absolute science fiction, but it is actually a brilliant piece of testing.
It really is brilliant. To test for mucosal irritation ethically and accurately, scientists use the membrane of a fertilized hen's egg.
Literally a chicken egg.
Yes, literally. That specific membrane is highly vascularized, meaning it's just packed with tiny, visible blood vessels, and it is incredibly sensitive. It serves as a perfect proxy for human mucosal tissue.
Okay.
If you apply a substance to this egg membrane and it is a chemical irritant, you will instantly see those tiny blood vessels hemorrhage or coagulate or undergo hyperemia, which is basically severe swelling.
Oh, wow. So it's a real-time window into inflammation. You could see it happen.
Immediately, yes. And they score the reaction on a scale where anything over a 5 is considered the danger threshold for severe irritation.
Okay, so a 5 is bad. Where did this base score?
When they tested the anhydrous on the egg membrane, it scored a 2.5 on the irritation score.
Just a 2.5. That's half the danger threshold.
Exactly. It proved the base is highly biocompatible and fundamentally non-irritating to those really delicate vascular networks.
That is such a relief for patients.
And beyond just not irritating the tissue, the base actively helps balance the environment. Testing showed the base maintains a mildly acidic pH of 4.56.
Oh, which ties right back to our baseline from earlier.
Exactly. If you remember, DIV patients suffer from an elevated pH because their lactic acid-producing bacteria have been wiped out.
Right, the missing lactobacilli.
Yep. By physically maintaining that acidic 4.56 environment right there on the tissue wall, the base actively helps fight off opportunistic secondary infections while the tissue is just trying to heal.
So the base is literally doing quadruple duty here. It's physically shielding the tissue, it's locking the medicine in place, it's refusing to wash away, and it's acting as a chemical pH buffer.
Yeah, if we connect this to the bigger picture, you can finally see the ultimate synergy of this treatment protocol for a DIV patient. The emollient base acts as a physical hydrating Band-Aid.
Right.
By clinging to the mucosa, it traps existing moisture in the tissue, immediately soothing the rawness and preventing that painful osmotic pull we talked about with the commercial creams.
The propylene glycol problem.
Exactly. Meanwhile, the microemulsion it forms is slowly, consistently, and precisely feeding the hydrocortisone directly into the inflamed cells.
And once that hydrocortisone actually penetrates the tissue without burning, it goes straight to work on the cellular chaos. It forces that rogue immune response to finally shut down.
Right, the alarm bells stop ringing.
Aggressive neutrophils finally retreat. And because the inflammation stops, the rapid shedding of those immature peridosal cells stops.
Exactly. The bricks are allowed to stay in the wall and actually harden.
That's the ultimate goal, right? Together, the hydrocortisone and the anhydrous base create this protected, perfectly pH-balanced sanctuary. They give the vaginal mucosal barrier the time, the steady medication, and the exact environmental conditions it requires to finally rebuild itself from the ground up.
It really is a massive leap forward in treatment.
So what does this all mean for you? Whether you are managing a difficult diagnosis yourself or you're just fascinated by the sheer mechanics of medicine. It means that treating a complex, destructive condition like DIV is not just about throwing powerful steroids at a wall of inflammation and just hoping they stick.
No, not at all.
It is entirely about respecting the microenvironment of the human body. By taking a crucial anti-inflammatory and compounding it into an anhydrous, self-emulsifying, mucoadhesive base, modern pharmacy takes a treatment that used to be an agonizing necessity and transforms it into a targeted, soothing, barrier-restoring cure.
It's a beautiful thing.
It really is the ultimate proof that in the world of medicine, the vehicle carrying the drug can be just as heroic as the active ingredient itself.
What's really fascinating here is thinking about the future applications of this exact science.
Oh, absolutely. Where else could we use this?
Well, if a self-emulsifying, completely water-free base can so radically improve drug retention and tissue healing in the vaginal mucosa by perfectly adapting to the local fluid levels, I mean, how might this compounding technology revolutionize treatments for other notoriously difficult mucosal surfaces in the body?
Oh, wow. Like where?
Think about the highly acidic gut lining, or the constantly moving respiratory tract, or even the incredibly delicate surface of the human eye.
Oh, right, because those all have moisture and they all flush things out constantly.
Exactly. Keeping medicine precisely where it's needed, without it being flushed away by the body's natural defenses or causing further irritation, has always been one of medicine's greatest hurdles.
It's the holy grail of drug delivery.
It really is. And this anhydrous technology, this smart release compounding, might just be the blueprint for overcoming it entirely.